no conflicts of interest. As the title suggests, this presentation centers on a case where a parent gives her child cannabis to manage behavior. Dylan is an 11-year-old boy who is being evaluated by one of my psychology colleagues in our autism clinic. His primary care physician has referred him for diagnostic confirmation of autism spectrum diagnosis. Dylan's medical diagnoses include Dandy-Walker malformation, hypotonic cerebral palsy, and visual impairment. And Dandy-Walker malformation is a brain condition characterized by multiple brain findings, but typically appears during infancy with slow motor development and rapidly increasing skull size. Dylan's social history is notable for intrauterine drug exposure, and he's been in foster care since age 6 with a foster mother who accompanies him to today's visit. Dylan is nonverbal, he is ambulatory, and he has severe self-harm behaviors that require helmet use and splinting of arms in order to prevent injury to himself. He has the cognitive functioning consistent with a typical 8-month-old, and at today's visit, he's given the diagnoses of autism spectrum disorder level 3, which is the level requiring the most substantial support, and of profound intellectual disability. When the clinician is talking about possible treatment strategies for Dylan, his foster mother reveals that she has been giving him a tincture of cannabis, 1 drop in the morning and 1 drop in the evening. And she makes this from a recipe that she found online that involves soaking the cannabis in vodka. She uses a type of cannabis called Charlotte's Web that has low psychogenic properties, and she reports that Dylan has been much calmer since taking the cannabis, and even at times she can take off his helmet and his splints, which allows him increased mobility. So to briefly give you a little more information about marijuana, there are 2 primary active chemical compounds in marijuana. The THC is the psychoactive compound that recreational users typically want to get that typical marijuana high, and the cannabidiol, or CBD, is the non-psychoactive component. The type of marijuana that this foster mom has chosen has very minimal THC and actually has been cultivated for its high CBD content, and initially was developed for a girl named Charlotte who had severe intractable seizures. I have spent a portion of my career doing adolescent medicine. And those of us who advise teens typically tell them that marijuana is not good for developing brains. So when we hear a parent say that she has been given cannabis to her child, my first reaction is, this cannot possibly be a good thing. So that gets us to the first question of how should the clinician approach these type of situations where parental choice may be placing her child at risk of harm. Since Oregon legalized recreational marijuana last year for those 21 and older, we've been hearing a lot more anecdotal reports about parents who have been giving their children cannabis for a range of medical and behavioral conditions. And when I did an internet search putting in the words cannabis and autism, the first 9 sites actually supported cannabis use for children to help manage behaviors. So it's really important that we approach these situations in a thoughtful manner because they are likely to become more commonplace. That gets us to this next question. Is cannabis administration harmful to this child? And as clinicians, when we are considering harm, we typically stratify both the risk and degree of harm. If we deem the risk to be low or the harm to not be serious, we may choose to tolerate the parent choice. We may choose to discourage parent choice, and typically we provide additional information to the parent. And that brings us to this third question about the harm principle. And Doug Diekema and others have written about this. And this is the concept that if a parent's choice has significant risk of serious harm, the state may intervene. And this is obviously a serious step. It may jeopardize the relationship that the clinician has with the family and may have the adverse consequence of making them be less likely to seek medical care in the future and less likely to share important health care information. This is an ethics conference, so I have to talk about ethical principles. Generally, the principle of beneficence guides much of our clinical decision-making. The clinician only offers medical options that are more likely to benefit a patient than harm, and we expect a parent's choices similarly to benefit and not harm her child. But assessing benefit and harm is not always easy, as this case illustrates. And commonly, clinicians and parents may disagree about level of harm and benefit. In this scenario, the clinician needs more information. Specifically, what do we know about cannabis and children? We've heard about the mother's perspective of benefit that the cannabis is affording to her child, and the clinician learns upon further questioning that she has been following other medical recommendations and is using it as a complementary therapy to other recommendations. Should talk a little bit about complementary and alternative therapy. The majority of parents of children with an autism diagnosis have tried at least one form of complementary or alternative medicine, and the severity of behavioral issues correlates with the likelihood of having used CAM. Why do parents use CAM? They have very likely heard about benefit, either from other families or internet information, that these therapies may help their child. They may have experienced or heard about adverse effects of other therapies that have been prescribed. They may consider these therapies to be safe and more natural, and they may have been dissatisfied with the effect that other therapies have had for their child previously. In the articles that I reviewed for this presentation, there were many types of CAM described, from mind-body medicine such as yoga, massage, nutritional supplements, diet, particularly gluten-free diet, hyperbaric oxygen, chelation, immune therapy, antibiotics, but actually none of these articles mentioned cannabis. The American Academy of Pediatrics has a statement about marijuana in children and adolescents, and they are opposed to it, no surprise. But they do go on to have the statement saying that marijuana may be an option for children with severely debilitating conditions. I am not an expert on cannabis, so reviewing information for this presentation, I tried to put aside my initial response that cannabis cannot possibly be good for this child and approach the questions of harm and benefit of cannabis the same way that I would approach another clinical question. I pulled review articles and then pulled the primary studies cited that point to benefit and harm, and reviewed some of those. We know that the prefrontal cortex does not fully develop until the mid-20s, and this makes us concerned about the vulnerability of the development brain and effects of cannabis. And there are many studies that point to a whole range of possible harm from cannabis use during adolescence. And these are looking at adolescents who use cannabis or marijuana for recreational purposes and had a history of regular use over a variously defined period of time. The list of harms cited in these studies include reduced overall IQ or reduced verbal IQ, poor sustained attention, deficits in abstract reasoning, increased impulsivity, decreased executive function, increased gray matter, decreased gray matter, and decreased white matter. But many of these studies had inconsistent results. Even though sometimes they were looking at the same measures, the results did not always match. And most concerning to me, they did not look at the function of those teens who were using marijuana prior to the onset of the marijuana use. So it's certainly very possible that those who end up using marijuana on a regular, frequent basis may have been different prior to using marijuana, and maybe even had differences that predisposed to their marijuana use. There is the inability to quantify the cannabis that was used. It relied on patients' report about the frequency, and there are no measures of the quantities of cannabis consumed. And we assumed that these teens were using marijuana that was high in THC. That's the whole point of recreational marijuana use, which would be a different form from that our patient is using. So the bottom line is there have been no studies published on the use of cannabinoids for treatment of health conditions in children or adolescents. So it's unclear how or even if these findings apply to our patient, Dylan. Looking for studies of benefit, there are really no studies that have been published showing benefit of cannabis to children. I did find a testimony from Nora Volkoff, who is the director of National Institute for Drug Abuse, and she was giving testimony to a Senate subcommittee, and she pointed to preclinical research that has shown CBD to have a range of effects that may be therapeutically useful. And among this list, the one of possible anti-anxiety properties is probably most relevant to our patient, Dylan. But here again, the studies are not great. The studies that Dr. Volkoff cited are small case studies, single studies, or use animal models that have not been translated to humans. Those that do look at humans consider adults only, and here again there have been no studies that look at cannabinoids in children and looking at sort of safety profile or benefit profile. I wanted to mention briefly the prescribed medications for self-harm behaviors in children with autism spectrum diagnosis. There are two medications that have been approved by the FDA. They are the atypical antipsychotics, risperidone and aripiprazole. There are many others used off-label, but in the sake of time, I will only mention these two. And these two medications have side effects, some of them that can be quite significant, that include weight gain, sedation, elevated prolactin, metabolic changes, movement disorders, and there's some animal evidence that risperidone taken in early life may be associated with hyperactivity later in life. But here again, an animal study that has not been translated to humans. So now we will get back to our case and putting all this information together, what did the clinician choose to do? It's important to say first that this child was in DHS custody. So even though the foster mother provided care for him, she was not his legal guardian, but she had been very forthright about her treatment decisions, and this child's DHS worker and supervisor were aware of the cannabis use. The clinician decided not to recommend cannabis, but she also decided not to discourage cannabis use for Dylan. She did talk to this foster parent about the lack of information regarding both short-term and long-term safety, and she did recommend that another observer look at Dylan after cannabis use to hopefully confirm the positive benefits. She also had concerns about whether this information should be included in the medical record. And she was a little bit worried that after putting together this sort of thoughtful approach to Dylan, that others might see this information in the medical record and not be as cautious with it as she was. And she decided to make notation that mother was using complementary medications but not specify those. I proposed that an alternative approach would have been to document the cannabis use, but to briefly describe the decision-making with her approach to this mother and child.